On this one, I think on the others, I've got some sound as well that goes with it, which probably will be all right here because there's not too many of us. But how are you going to use it for recording? I've no idea.
So you want to move forward?
Don't know. It's as much
no, we
as
have the audio there, and we will sync the audio and video.
Okay.
Because the microphone in the camera is really bad.
Yeah, well, that's really bad. And all I've got for the sound is on this thing. So you don't have any little speakers, do you? Okay. Let's hope for the best. I mean, the main thing, the visual side of it is it's with Parkinson disease and things like that. So I'll leave the door open to start with. So this is the 3 final lectures on the bionics course. We're looking first of all at use for therapy, neural interfaces, and particular example being Parkinson disease. Then we're going to look at human enhancement, which is a growing interest in all sorts of different areas, and particular aspects. I'm not going to look at the type of human enhancement for life extension, that's sort of one area, but other than that, probably look at most of the other aspects. And then going to conclude with some of the what are called the bioethical aspects of the whole bionics area, so the lighter, more social side of things. But we'll see what that actually means in practice, whether it actually means ethics as we would think about it or not. Now, we're just discussing earlier, because there is an exam that goes with this, those of you that are interested in getting a grade and so on. I'm going to be back across here in May, about 1 month's time, and that does present an opportunity. I don't know how that fits for you guys, whether May is a possibility, so in which case we might go for that. So I'll have to come up, normally it will be an essay of about 2-3 sides of A4 on the subject area, and then we'll be back in here to do an exam which is mainly discussing between us the essays and what's content and things like that, and then everybody gets an A grade and everybody's happy. So right, here we go. So we'll try and schedule that for May. I will be back over later so we can pick up if somebody can't make that particular one. It's no problem. As I said, I'm doing an exam from last year today, still catching up somebody who was away for a bit and so on. So I did last time talked about different therapeutic applications, obsessive compulsive disorders and Tourette's syndrome and so on and so forth. But if we're looking at therapy, I think quite clearly at the moment the main use in therapy for implants, neural implants, interfaces, is for Parkinson's disease. So I'm going to concentrate on that. Just have a look at what it's about, see how deep brain stimulation can actually help, and then look at some of the latest research, which some of you may be able to assist with and say something yourself about some of the problems and so on. Oh, hi. So I may well call on at least one of you to say some words about the research. What is it? Parkinson's disease is a degenerative disorder, so it tends to get worse. In different people, it can get worse a lot more quickly. Other people takes longer period of time. it comes under a group generally described as movement disorders, but there is a lot more to it than that. Movement is one of the aspects. John, we've only just started, you're fine. So things like rigid muscles, and this muscle rigidity links in with spasticity, it links in with things like cerebral palsy, so a lot of these neurological problems, there's a lot of overlap. It's not really the case this is Parkinson's disease, there's a lot of issues. But one thing that is a characteristic with Parkinson's disease is the tremors. It's interesting, it is specific to Parkinson's disease, but if you do feel you've got some tremors, and sort of oscillating movements, the most likely cause of it is alcohol. You've been drinking too much, so don't panic. No, alcohol is one of the worst cases for rather than Parkinson's disease, for tremors. And so stop drinking so much and you probably get rid of it. But slowing movement is another thing. And the akinesia, loss of physical movement, best seen now in English, the title of the film was Awakenings. I'm not sure what the title is in Czech. It's based on a book by Oliver Sacks. I don't know, certainly if you can have a look at it, if you like, as homework from this course, this whole akinesia, where complete can be, in the extreme cases, complete loss of movement. And the film Awakenings with Robert De Niro and Robin Williams is a very, very good example of that. It's a really good film. And as we see, it's if you like, one of those true story type films, but it shows you when you get this extreme case of complete loss of movement, and the potential treatment with chemicals, a lot of the dopamine, as we'll have a look at. What exactly is going on with all of these problems, we don't really know. The primary symptoms for Parkinson's disease appear to be decreased stimulation of the motor cortex by the basal ganglia, and the formation of action of dopamine, so chemicals produced in the dopaminergic neurons. So the typical treatment for this was just replacement of dopamine, levodopa, so chemical treatment. But of course the human brain is electrochemical, so you're looking at two potential ways of treatment, the electrical or chemical. You can get, I say it's movement problems, tremors, muscle rigidity, slowing of movements, or even complete loss of movements. There's then other symptoms. Not everybody gets these. Cognitive dysfunction, brain stops, you stop understanding things. And one that does occur, language problems, in the sense, typically, the person may be speaking to you, but you can't understand what they're saying. That, as far as their brain is concerned, their words are coming out okay, but what the hell, it's very, very difficult to understand them. So things like that are typically the secondary symptoms. But as I said, not everybody experiences all of the symptoms, and just because you get one of the symptoms does not mean you've got Parkinson's disease. So if you have some muscle rigidity, it probably is not Parkinson's disease. If you have tremors, as I said, the most likely cause is you've been drinking too much alcohol and things like that. If you slow the movement, doesn't mean you've got Parkinson's disease. But put them all together, It's chronic. Once you've got it, you've got it. It's progressive. It gets worse. It affects movement. It is more generally an older person's disease. But having said that, younger people can get it. You know, all ages can get it, but it's very, 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 very unlikely that you get it younger. The average age of onset of Parkinson's disease is 61, but that's just a statistical average. The average life expectancy is not actually too much affected, but would be about 9 years. But that's just sort of typical for people aged 61 around the world. So it's not a. I think that might be increasing now as people live longer. So it is generally an older person's disease, which means that it's on the increase. It's increasing. More people are affected by Parkinson's disease now than used to be. That doesn't mean it's catching it means that more people are living longer, that more people are living to be older, and hence more people are getting Parkinson's disease. In a way, to say more people are getting Parkinson's disease, we should be going, yeah, great, that's brilliant, more people are getting Parkinson's. I mean, I know that's a strange way of looking at it, but it's exactly the same to do with more people are getting skin cancers, more people are getting dementia. It's because more people are living longer. But it does mean it's becoming a more important problem because a lot more people are affected by it, and it's costing health services and so on a lot more money. Coupled with it, you get mood disorders, behavioural problems, depression and clinical depression is sometimes seen either as a sideline for it, but it's very easy to see if you have Parkinson's disease, it's not pleasant, and you know it's getting worse and getting worse. And typically what happens with the chemical treatments, they might have a reasonable effect to start with, and then, as with any chemical, it starts to wear off a little bit. So you get depressed. So this, to call it a symptom, it's something anybody who's got Parkinson's disease is going to be pretty depressed with it. It gets you down. It's very difficult to be happy with it. But there are different symptoms, and how quickly it gets worse, how much it progresses, depends on the person. And there's so much that is not known about it. How can you reduce the progression dependent on how you are? The tremor is about 4 to 7 hertz. This is that sort of tremor that you see with movement. And it's a resting tremor. So when the person is relaxing, that's when the tremor tends to come on, but it may, some days it's worse than others. Some days the person may not feel it at all, and then other times it can't stop the thing. And decreased with voluntary movement. And this is intriguing, that if somebody who has a tremor there and you throw a ball at them, they will catch the ball perfectly okay, no tremor at all, but then as soon as they relax with the ball, the tremor comes back again. So the voluntary movement overrides the Parkinson's disease and action. You also then get rigid, sort of muscle locking, stiffness, if you combine that with the tremor, it becomes a sort of bit like a robotic-y movement for the person. This cogwheel sort of moving in bits, like as though they're strobe lighting how the person moves. And then the akinesia, with the complete, either very, very slow or complete loss of movement. The postural instability was something when Parkinson first described the problem, described the disease and looked into it. That was one of the things he concentrated on. First of all, person walking with a hunchback type of thing, but then falling over. And as we see, either walking faster and faster or slower and slower and so on, and simply losing the ability to control movements. So shuffling along, arm swings problem, turning on block, again the concept of strobe lighting, so you're sort of moving a bit like the robotic type of movement. Faster and faster gait until you just fall over, like those little things that you get, the little robot things that walk down slopes and so on. Muscle contractions, gait freezing. Again, different people get some of these things. Some people get just about all of them. Quite a few people don't get speech problems, but some do. Soft speech. So the person talks as though for them it's okay, it's quite loud, but you can't hear what they're saying. So you're constantly trying to... again, if somebody has a problem of soft speech, it doesn't mean they've got Parkinson's disease, it's just one of the problems. Monotonic speech, so most lecturers have that anyway. Poorly intelligent, this is more, you can't understand, drooling, facial expression problems. Again, other symptoms, fatigue, so they're tired out. Half the cases say that. Doesn't mean if you get fatigue, you get tired, doesn't mean you've got Parkinson's disease. Everybody gets it, but again, it's not surprising with all of the other symptoms that people find they're really tired from it. Problems of getting up, cramped handwriting, poor arm swing. So different symptoms that a number of people say they've got. Mood disturbances, depression, and this depression, it could be there anyway. Is it anything to do with apathy? They just can't get on with it. Difficulties in attention, impulse control. This is interesting. One of the side issues that is linked with Parkinson's disease, either in the disease itself or as for the different treatments, as we'll see with the deep brain stimulation, you have in a small number of cases, voyeurism. This is, enjoying disgusting sexual acts and things like that, or watching them anyway. And gambling is what gambling, and some people who have never gambled in their life, when they get Parkinson's disease, will find they can't stop. And it's the same for one of the negative side effects in a small number of cases for deep brain stimulation is gambling. It's a real strange thing, that part of the brain that causes you to do stupid things like gambling, that you can't stop it, that you have to bet on whatever and so on. Absolutely incredible that there's some part of the brain to do with that is linked into movement and all sorts of things. Interpreting social cues, and there you get links to autism and Asperger's syndrome. Again, different neurological problems, but exactly that. Time awareness, the same. Again, dementia, and because it's an older person's problem, Parkinson's disease is an older person's problem, so people who have Parkinson's disease, almost a third of them also get dementia. So you think it's bad enough having Parkinson's disease, well, then you get dementia as well. And with all that abstract thought, memory problems that go with dementia, behavioural problems, delusions, paranoia, it's all linked in together, that you think you're somebody else. My mother, who had dementia, she didn't have Parkinson's disease, although her father did, my grandfather did have Parkinson's disease, but she had dementia, and in a last few years, she thought she was, again, she was about 3 years old in her mind. She was a little girl, and she kept wondering where her mother was, and she was asking me, I'm her son, and she's asking me where her mother is. Her mother, of course, died about 50 years ago, and so on. So things like that sort of you just think the world is completely different. And this is all linked in short-term memory loss, sort of medium-term. I mean, we know a lot of people with dementia have a sort of a 10-minute memory. You talk to them about something, and then a few minutes later they've just completely forgotten about that. And you can go around the same conversation time and time again. It's interesting, and it's the same with the deep brain stimulation. Some of the symptoms can be improved through chemical treatment, dopamine, but others get worse. So you may benefit in some ways, but get worse in other ways. And again, sleep disturbances. I think sleep is any neurological problem you have sleep problems. If you have sleep problems, it doesn't mean you have neurological problems. You might be worrying about stuff and whatever, or you've drunk too much, or whatever it happens to be. I'll just quickly go through those. So, problems with sleep, vivid dreams when you do sleep, sleeping in the day, which is the opposite thing, sensational disturbance, visual problems to do with colour, dizziness and fainting, which links with postural problems. Your sense of smell can disappear altogether. Pain issues that you can have, either you can feel pain or you don't feel pain. Your skin gets all oily. You keep peeing all the time, or you have difficulty peeing. So you get up to 60% of cases keep getting up in the night time, but this is sort of about once an hour you're getting up in the night for peeing and things like that. Altered sexual functions, and in different ways in different people. This is interesting, weight loss. So the person loses weight, but again, it's all linked in together. So, and again, not everybody has all of those symptoms, but people would have, you choose, have a bit of this and a bit of that. So again, it's from the dopamine secreting cells, but again, why that is and how it's controlled and so on is a question. And different theories. So there's some basic ideas, clearly affects the motor cortex, but affecting different parts of the brain as well. There's still so much that is not known about it. Treatment for it. Well, when you've got it, you've got it. So it's not like something that is directly cured in that way. Dopamine, levodopa, plus perhaps other chemicals. So that's the standard traditional chemical treatment. A person, as well as that, if they have speech problems, may well go to a speech therapist to help them pronounce words more so they're better understood. Physical exercise of some kind, yoga or swimming, those sort of things. And particularly in latter stage, when chemicals start to wear off, surgery Now it's deep brain stimulation, but it didn't used to be. Parkinson's disease, it's not, if you've got it, that doesn't mean you're going to die, that's it. So it's not like motor neuron disease, where if you're diagnosed with motor neuron disease, you could be given 3 months to live, or it could be less than that. This, the average life expectancy, it is a little bit lower, but it may well be sort of not as a direct result. It's not like the disease itself is killing you, but because of the disease you may catch pneumonia, or you may fall and falling. So it's like with epilepsy. Epilepsy it's not a killer in itself, but you could fall in front of a car or something, or lose control while you're walking over a bridge, or it's that sort of thing. And it's the same with Parkinson's disease. So in a sense the life expectancy is the same, but in another sense it's perhaps not so good. And progression can take 20 years or longer. It can be very slow. And again, it's not really known why in some people it's quicker. Very difficult to predict and so on. So people with Parkinson's disease can and do work and live a productive life. Clearly there are some jobs potentially that may be difficult for them to do, particularly if they have tremors and so on. But it doesn't mean that's the end of your working life by any means. Surgical treatments. Well, before dopamine was discovered or used, which is relatively recent, surgery was the main method of treatment, but not in terms of deep brain stimulation. Surgery involved a lobotomy, and lobotomy literally was cutting out part of the brain or dissociating part of the brain from the rest. So it sounds terrible, coming out. Well, I suppose it was terrible, or is terrible, but it means snipping out a few brain cells, effectively, cutting them out of action. And because even then surgeons don't know exactly what they're doing on this, and people are affected in different ways, so the success could be very dramatically different. For some people, it could be fine, cut out a few of the brain cells and that's it. They effectively don't have Parkinson's disease. But there could be side issues. Maybe they have memory loss or some other, but it could be not as problematic. For other people, they'd have the operation and it wouldn't affect, they'd still end up with Parkinson's disease, and maybe the symptoms would be worse. So it's very much a case of trial and error, but that used to be the only treatment.
Can I have a question?
Yeah.
What part of the brain they affect with the lobotomy when they cut it?
As we will see, the main areas of the brain where the stimulation is applied is right in the middle, the thalamus or the subthalamic nucleus. And my understanding is that typical lobotomy used to be cutting out part of that, but more how they interact with the other parts of the brain. But I could be wrong on that, because that surgery does involve drilling right down into the middle. So, in essence, the answer is I'm guessing. But I think in our answer also, I think the surgeons were and do cut out of you and hope and see what happens. My father had agoraphobia, which meant he is the opposite of claustrophobia. And he had it really bad. So he didn't have Parkinson's disease, but he had this agoraphobia. And in the end, what they call a lobotomy is like a leucotomy, which is like a mini lobotomy. I mean, I think lobotomy is used to, but that was just under the surface of the brain. So essentially, as he described it, they drilled a couple of holes and then just drilled in towards the top. But they must have, because it's just motor cortex and stuff there, so they must have gone in a bit deeper. But I'm not sure they knew what they were doing, and they don't do that now for agoraphobia, but they did at the time. So again, having talked to quite a few different surgeons, you probably find that if you talk to one surgeon, they would say, yeah, well, we go in and we would cut out this region. And then you talk to another surgeon, and it would be a completely different region. But they have different methods of, even with the stimulation, there are 3 different areas of the brain, and different surgeons prefer to go into certain areas of the brain, different. So it's, so I don't know that I have a good answer for you, but I think if we had 10 surgeons here, we'd probably have 20 different answers on that, which is quite worrying. You think with the medical, they know this is it, that's where to go, but not. And even now, where dopamine is the traditional treatment, chemicals tend to wear off after a while, or if the problem degenerates, and then surgery is used. It does depend on the person wanting it, though. Although Parkinson's disease is a pretty awful disease, it's not that surgery is enforced on the person. They would have to agree to it, which you hope their cognitive functions are okay. Not everybody wants it, and you do get, I'm aware, a friend of my wife has Parkinson's disease. She's in her mid-60s. She doesn't want deep brain stimulation because it involves wires being that you can potentially see or feel under the skin, and therefore she doesn't want to appear that she has these wires under her skin. Now, yeah.
How this deep brain stimulation is actually working in this?
We will see, and I will bring in. We're going to have a look at different examples of that. Although again, that's a very good question. Which it works, but how is it working? There's different theories, and I thought you might have a view. Help me out on that one. But I think we don't know. It's one of the main. It's one of these things. Seems to work fine. And if we do this, it works a little bit better. And if we put the electrodes in here, it works a little bit better. And if we use these frequencies, it works a little bit better. But again, it's different on different people. The frequencies, the magnitude has to be adjusted for people. But how it works exactly.
And technically, it's a simulation by electric impulses.
Yes. Yes. Yeah. We'll look at that in a few minutes and some video clips, and we can discuss that more. So. In fact, let's get on to the fun stuff as quickly as possible. So this is, I think I probably showed this before. What happens is they very, very thin drilling down into, and so we're talking right in the central part of the brain, one of 2 or 3 areas in the central part of the brain. And then which we will see in a second, they push it's a thin, quite flexible wire with electrodes at different points on the end. The older ones had 4 electrode positions. Now the newer ones have 6. But I'm not sure whether that is helpful. It might be more they have 6 because there are more surgeons doing it, and more surgeons don't know what they're doing, so it gives them a bit more flexibility. But I don't know. And the surgeon typically will choose which of those electrodes is the best one, but you can get results comparing the signals between the electrodes. And Oh yeah, how does it work? But I don't know that this is the answer. It's not clear how it works. So the basal ganglia circuitry, so this is more just suggestions. I don't know, this is so you get these spontaneous oscillations. It's thought that in Parkinson's disease these rhythms become larger, more synchronous, slower and uncontrollable because of the lack of dopamine. But sometimes the surgeons will think rather than them becoming larger, the rhythms become smaller. The electrical stimulation affects in a complex way, but again, it's thinking of electrical stimulation. It can be as well as chemical, the dopamine, or it can be instead of. But typically the person may well have deep brain stimulation and take the dopamine as well. And it seems to be the stimulation is blocking out some of the oscillations. Some surgeons you talk to describe the stimulation as having the same effect as a lobotomy. It's cutting out the interaction of part of the brain, so it's doing the same thing, but that might be just how the main thing is losing the tendency for oscillation in there. So the suggestion, deep brain stimulation probably works because it takes command of the networks, stopping them getting into the particular cycles that they try and do. These words are just taken from the one surgeon I work mainly with, Tipu Aziz, and he says with deep brain positioned in the thalamus only, it just reduces the tremors. This is one surgeon's opinion. Most patients are affected by other things, muscle locking and rigidity, and in Tipu's words, he feels if you do deep brain stimulation there, it doesn't have any effect on this, it just stops the tremors. And so he positions in the subthalamic nucleus so that it affects tremors and muscle locking. But that's his, so I'll put that down, positioning, but that's really one surgeon. So this does have sound, but it's in German because it's taken from a Swiss hospital. But you see, this is an actual operation. The person's head is held in a frame, has to be kept there. The operation typically might last 8 to 10 hours. So this is you can see it's quite a flexible electrode wires, as it were, but it has to be fine-tuned. So that's putting those right into the centre of the person's brain and then fine-tuning the position. And it's linking the fine-tuning of the position with the tremors that we can see there. And that's what the surgeon is doing. Now, I was saying about sound on here. We don't have sound on here because I haven't got my sound switched on yet. But as I say, it would be in German. I'm not fluent in German, I have to say. But you can see the surgeon trying to fine-tune, and he is in fact talking to the patient and saying, how does that feel? Is that better? What's it like? And so on. So the patient is feeding back, but it's visually seeing the tremors dying away. This is in the operation. The patient is part of the experimentation, and we see there, I think at the end of it, the tremors have just about stopped altogether. In fact, I'll turn the sound on while I remember to do it.
Is the patient conscious? Or?
Oh yes. The anaesthetic, in fact, I'll switch that back on and read it. They only have, because you don't have pain receptors in the brain, you just have anaesthetic at the point of the incision. it's the only place you feel pain. So the person is completely conscious, awake. They're very much part of the operational procedure. The feedback is important for the surgeon for the patient to say, yeah, that's much better, or no, I've still got the tremors, or it's good in this hand. Yeah.
Do they just drill through the skull, or do they remove the complete bone?
It's just a very, very small, as we saw, drilling right down in, so taking out that very, very thin part of the brain there. But it would be, if it's a right side and a left side Parkinson, if let's say it's a left side, then it's pushed into the right side of the brain, and vice versa. But if it's a both sided Parkinson, then they would need two electrodes to cover that. But the fine tuning would be done separately for both sides. So it may well be the current and the frequency on one side of the brain could be a bit different to the current and frequency to help the other side of the brain.
They just stimulate the brain and then they remove these electrodes?
No. The operation takes 8 to 10 hours, as we saw part of it there. A lot of the earlier part of the operation is putting the person's head, fixing it into that frame that you see. It has to be kept pretty firm, and preparing the patient for the head's already shaved before, but they would then try and fine-tune during the operation to improve things as much as possible. But typically, the patient would have effectively wires coming out of their head for 1 week or 2 weeks after the operation, and then they would go through another exercise where the surgeon will perhaps check on the fine-tuning, check on the frequencies, and see if it can be improved before the power packs are inserted, and then you have the power packs here and then wires into there, so that just for a week or two the electrodes are in the brain and they're sort of left there apart from testing. So that's, but no, you had a look at the operation in practice. I don't know whether you want to add anything to that or put a different view or opinion.
No, it's basically the same. They leave it like this for a few weeks for observations, and once half a year, each half year the patient comes back and they adjust the new values for simulations, like a little more.
So it's like sending impulses all the time.
For next, can you do?
Oh yeah. I mean, yes, yeah. When it's switched on, it's switched on. I mean, as we'll show you can inductively switch it on and off, but we'll see what happens when you inductively switch it off in a second. But it's left on all the time, typically, because one of the big issues. Oh, a number of issues, but one of the sleep problems, particularly when you see with the tremors, and it is a resting tremor, and when you're sleeping, you're resting. So for one of the worst points of the problem is that a person's trying to sleep, and they've got this going. Sleeping like that is just about impossible. So it's left on, and you can actually sleep, because you've got rid of the tremor. So it is left on all the time and it's stimulating all the time. But the surgeon is in the operation and for the next week or two, and as Eva said, every 6 months or so, is fine-tuning the position of the electrodes, deciding which electrodes are probably the best ones to use, fine-tuning the frequency. The surgeons refer to it as a high frequency stimulation. They say it's a high frequency. What it is anything from about 130 hertz to 180, maybe 190 hertz, that sort of region. And it does vary, and one of the things they're adjusting is the frequency. But when surgeons say high frequency, they mean this 150 hertz typically. And then they're adjusting the magnitude of the current as well. And then, so it's a combination of those things. The power pack is the same shape as a heart pacemaker. It's a bit bigger because it needs more power. It's in a titanium casing. This is what's actually implanted, and you then connect this up by wires to the electrodes that are positioned, and the wires. So the power packs are positioned here, as we will see in a second, and then wires underneath the skin into the brain. You may need one of these on the right and one of these on the left side. But it's all then the surgeons like it to be all implanted. Now, I think I've got a video clip. This is one of Tipu's patients. There is sound on this, so let's hope you can hear some of it.
I'll try again, and after a couple of attempts, I managed to say, Mary had a little lamb, its fleece was white as snow, and everywhere that Mary went, and I knew that was bastard. Eventually he said to me, a few more millimeters to go. I was trembling, desperate. And suddenly, my trembling stopped dead. Absolutely dead. As he touched the spot. So he said, I'm going to knock you out, and I'm like, and I'm going to run the cabling. So he ran the cabling into my chest. I can control my tremor. As you can see, it's fairly well controlled. I have a right side Parkinson's. At the moment, I have, I think, 3.3 volts going into my brain. It goes in for 90 millionths of a second, the pulse, and it goes in 130 times a second. So it's a fairly snappy gizmo. The point is that you are thinking only of Parkinson's all the time. Because your whole mind's obsessed with this. Parkinson drifted across your eyes all the time, just and not being able to concentrate. Not being able to concentrate on what you're saying to people. So I'm quite grateful to Jim Bruce for what he did to me. And people will not accept it.
So, I'll give you some idea what it's about and the difference it makes to people's lives.
Is it helping also for other symptoms or just for the tremor of Parkinson's disease?
Is it helping?
For other symptoms?
Yes. Again, it's different people, which is, there you saw the case where the tremor just, overrides anything else. I mean, how somebody lives with that, it's difficult to imagine. And hence, for some of the surgeons, they focus on the tremor, and if somebody has muscle locking and things, so that's where they just perhaps go to the thalamus and overcome the tremor, and that's it. And perhaps leave the chemical, the dopamine, to deal with the, ease the rest of the things. But Tipu tries to go for everything with the surgery. So he's I don't know how many people in Homolka they do it. But in the Czech Republic, do you know how many hospitals there are? Is it?
So far, I know Homolka and one's in Bratislava and Slovakia.
Okay.
In the Czech Republic, I don't know about it. Maybe it changed, but...
Yeah. Well, Czech Republic's what, about 10 million people, something like that. So so it's probably similar. In the UK, we're about 60 million people, and there are 6 or 7 hospitals that do it. Tipu Aziz, we actually saw him in the background, a little bow tie on there. He's the leading person in the UK at Oxford. He does implant typically one person a week, one of these operations every week, which means probably about 30 a year he does, because they get long holidays, surgeons. So that's sort of typical 30 a year, but there are then 5 or 6 others. I know in Romford in London there's another, but they're not as, Tipu is, would be the UK expert as it were in the field. He does a lot of work. In Oxford they have a big monkey house, and it's not particularly people in the UK are very much into animal rights, so he gets a lot of people throwing things at his windows and doors because of he gives monkeys Parkinson disease and learns positioning and so on with the monkeys. But there's Tipu for you. Still as we are, it's usually latter stage Parkinson's where chemicals are no longer working, and the first treatments nowadays would be dopamine. But as you saw there, the effects can be, and often are, for patients dramatic. It's almost somebody who hasn't seen it before don't believe it. They think it's an actor, or and life can be completely different for the patients. One story to show how it can be, I give different presentations, and I was happened to be in Norway, and during my talk, this was about also a woman came up to me, and she said she knew I was researching into Parkinson's disease, and so on. And she told me about her father, and her father had been a very active guy doing half marathons and all that, and then he got Parkinson's disease, which stopped it, and they gave him the deep brain stimulation. And she said his life, he was like a vegetable. He'd gone from being this really active guy to being someone they had to push around in a wheelchair and help to get onto the toilet and things like that, which he didn't like at all. And he couldn't communicate very well. And it worked dramatically like that. And within a few weeks, he started to get up and exercise, and within a month or so, he started to go out running, and a couple of months he was doing half marathons again and living his life. And after 6 months, he had a heart attack and died. And I thought she was going to kill me, if you killed my father or something. But she said, thank you. For 6 months we had my father back. He had his life back again. And that 6 months was more, if he lived 10 years with Parkinson's disease, it wasn't, the 6 months was worth it. So it completely changes people's lives. Here's another one. This I got, the main company that produces the deep brain stimulation is called Medtronic. It's a very profitable company. And I got this clip from them. This was taken at a Medtronic Christmas party a few years ago. But again, it's another patient, an actual patient. So.
I'm going to show you in 2 minutes what was the status of Mr. Pressman when he was referred to us by his neurologist in Belgium. And you see him before surgery, without drug, unable to stand up by himself. He's helped by Patricia who's a neurologist in our group, and he's not able to do anything of, as he will tell you, makes your life really normal. He's not able to walk, he has dystonia, which are muscular contraction, deforming the different joints, and this is the best he could do without the drugs, with the help of people around him and maybe his wife and friends. He was referred because the drugs were not working anymore. He was not having any improvement, and as he will tell you, was just to step to a wheelchair. This is after surgery. You see the tremor. You turn one of the two stimulators which were implanted with electrode into his subthalamic nucleus, which is a tiny part of the brain, and you see that in a few seconds the stimulation induces the stop of the tremor. This is still visible on the other side. We will turn on the stimulator on the right side, and you will see something even more spectacular than that. You will see that the patient feels again free, and he reset himself in his chair in the position where he feels the emotion. He will obey Dr. Pollack in doing some tests, even if he feels that those tests are a little bit useless as compared to the feeling he has. He can do that almost normally on the one side, which is a little bit longer, as we say, and we'll show it on the other side. And then he will walk, he stood up alone. He's without any drug. You see him walking, turning. It was a few days before the Vienna meeting, the movement disorder.
So, gives you some idea of the dramatic changes you can get from it. I don't know, was the sound okay? I think you get some idea anyway.
It was okay, but I think they had too much stimulation for the patient.
Too much?
Yeah, because he was, I was in English, he was moving spontaneously.
Yeah.
The surgeon told me that when they push too much stimulation, he can't start moving, he feel like it.
Yeah, well, it's interesting. So that is, it's about 10 years after. I think that originally not too far after when they first came out with the product. So it probably is now the surgeons have learned quite a bit as to what level to stimulate at for for regular life and so on. Now this is the bit that I need your input to this as well. So, research project, one of the issues with the stimulator, as it's stimulating all the time, it uses up quite a bit of power, and at the present time the patients have to go back into hospital every 2 years, say, to have the power packs replaced. So literally what happens is they unzip them, unstitch them, take a power pack out, throw it away and put a new power pack in place. It is possible to use rechargeable batteries, but I mean, I don't know if Homolka do any of those. Tipu doesn't at all. He doesn't use it, partly because patients don't want a rechargeable, but partly he doesn't think they're very useful anyway, because it does involve the patient lying down next to a recharging station for lots of hours every day, which is not particular. The patients don't want it. They just don't. They want, with the implant, they want to go and live their lives. So what we're trying to do with Tipu and others now jointly here, and what Eva's project is on, is trying to make the stimulators intelligent. So first of all, it recognises when tremors are occurring, muscle locking potentially is occurring, and then just stimulates when it needs to stimulate, not all the time. And what we also want and hoping for and can get in some patients is a prediction of the tremor so that the stimulation can kick in before the tremors actually start. So that's the idea of the research project, to have an intelligent stimulator that just stimulates when it needs to stimulate. The sort of signals that one's looking at is here. These are perhaps the more obvious signals. This is the EMG, the muscular signal associated with the tremor. So from this is an 80-90 second sequence. This were taken from an actual patient. So there's nothing much happening up until about the 50-second mark, and then this is where the tremors kick in. So that's showing the muscular movement. And for this particular patient, this is the electrical activity recorded from the electrodes in the subthalamic nucleus at exactly the same time. So you can see visually from this particular patient that the variation, the variant standard deviation of the signal diminishes here where the tremors occur. It's much greater at this point. But that in itself that's just in this patient. In other patients, you will find that the variance increases, and in other patients, you'll find there's not a lot of difference in there. So it's trying to use all sorts of intelligent techniques to firstly characterize from measuring this electrical activity when tremors are occurring on the outside without actually seeing the tremors, and secondly trying to predict when the tremors are going to occur before they do. So that's the idea. Now, would you like to say a word as to how easy or difficult or problematic, or you don't have to.
The problem is that we don't have too much data, because it's a problem to have a lot of patients and not data. So far for few of the patients, the results are quite good, like very simple. But for rest of the patients, we have almost no results. So we need to give more patients, and then we can make some statistics.
One problem is that with a lot of issues, a lot of medical things, you have a control group. So you have a group that is normal. And like we were talking earlier about EEG electrodes. So if you're looking at people with epilepsy and trying to study them with EEG, then you can also, bless you, take a group of people who are just normal and get normal activity. In this case, that's not possible, unless there are volunteers to have holes drilled in their brains when they don't have a problem. So here, all you've got are people with Parkinson's disease. If there was, let's say, a group of 10 regular people who didn't have Parkinson's disease, then the data from what's going on in the subthalamic nucleus could be quite useful, and then one could start looking at what is abnormal. So that's one issue. But I think another issue is that Parkinson's disease is actually an enormous disease, and as we've seen, it's different symptoms in different people, so it's actually manifesting itself in different ways, and hence it might be that, as Ivo said, there's a group of people we can treat in this way, but then another group of people maybe need to be treated in a different way and so on. But it's just that there's so much we don't know. We know about that much about Parkinson's disease, and we don't know that much. That is what it amounts to. And the treatment is sort of not guesswork, but it works, so why not? Oh, yeah.
If there's one other problem, that when the surgeons insert the electrodes, they have about 1 millimeter tolerance or something like that, or even more, a few millimeters. And that's really much from the point of the brain, Yeah, after yes, but they are not really able to. You can plan where to insert the electrode, but there is always some problem, and since some patients they have most of the patients they have a little bit different type of brain, so it's not so easy to make a universal positioning system when the shape of the brain is a little bit different.
And that was my question. You said you have no patients which are normal with all the disease. My question is, would it help actually, because every brain is a bit different, so maybe there is nothing normal.
Yeah.
You just have to learn on the patients because when they start learning, because other patients will have different.
Yeah, I tell you what you're saying. I think it would help. Just having, there was a group of 10 patients, this is normal. Because then we could say, this is definitely abnormal, this just doesn't fit at all. But I agree with you. I mean, it is a problem with everybody's body is a bit different. I mean, surgeons will have a general picture, this is roughly how it should be, but until they actually go in to operate, even though very simple things to do with bones, and it's a little bit different in everybody. The shape is a little bit different and so on. With the brain, of course, it's not only the shape and size of it, but the neural pathways and connections are a bit different dependent on all sorts of things. Their education and so on means the brain is slightly different. So it's especially, and it's in the volume, so you can't, even with scanning, it's giving very rough activity when the person thinks about sex, so this part of the brain is active. But even then you get big differences between people as to which parts of the brain, strange parts of the brain become active. So it's, but there we go. It gives you some idea. I mean, I've concentrated on it for one presentation because it is now quite widespread in the Western world, this particular deep brain stimulation. It is very, very successful. You may well come across somebody who has the problem, has the problem and is treated in this way. But it is an area where you can see, look, here's something that can make a big difference for people, and possibly in years to come for a lot of neurological problems that could be treated in a similar sort of way. But the same stimulator is used in fewer cases, but people with epilepsy and Tourette's syndrome and depression and so on that we looked at the other time. Now, let us have a 5-minute break. I can make a cup of coffee, and we'll have a look at human enhancement, and then we'll finish off today with the ethical side of things.